This is a routine case on a patient with a fairly significant Fuchs corneal dystrophy. Actually, the patient traveled to the United States to have surgery in the U.S. instead of her home country. This was because she needed macular hole repair and cataract surgery, and also has a fairly significant Fuchs dystrophy. You can kind of see it in these video. It's a little bit hard to see into the eye. She has about 3+ guttae on clinical examination, and she also has a pachymetry of 625 in this eye. Actually, the other eye was even worse. The Fuchs dystrophy had caused some scarring to start, and she had pachymetry of over 640. Usually my cutoff for just doing cataract surgery without corneal transplant is below 640. If they need a corneal transplant, I refer them to a cornea specialist to do a combined corneal transplant with phacoemulsification. There's only a couple of subtle differences in a case like this. The first one is that we want to make a smaller anterior capsulotomy. This is for a couple of reasons. One is that the retinal surgeon requested this because he's going to do a macular hole repair on this patient. He's going to put a gas bubble in the eye, and it's helpful if the anterior capsulotomy is smaller than the optic size. So I use a ZCBU with a 6mm optic, so I'm trying to make my anterior capsulotomy about 4mm and as round as possible. I don't want it to go out on any particular side. If it does, then you can have prolapse of the optic out of the bag, pushed forward by the gas bubble. Additionally, if the patient needs a DSEC or DMEC in the future, it's helpful to have a smaller anterior capsulotomy because the anterior chamber is collapsed by the corneal surgeon during unfolding of the graft. This can cause vitreous to come forward, especially if the anterior capsulotomy is large, especially in cases where the patient's had a YAG of their posterior capsule. So now we've finished our anterior capsulotomy and we've done hydrodissection. The lens hasn't spun all the way around yet. Nuclear disassembly is going to be similar to routine cases. The main thing is that we're going to try to protect the corneal endothelium as much as possible. At the beginning of this, you could see that I put additional Helon Endocoat into the eye to protect the endothelium. I'm going to speed ahead a little bit on my nuclear disassembly here. We're just going to make our normal crack and we're going to spin the lens. Then we're going to start taking out piece by piece. Instead of focusing on the total amount of CDE or energy used inside the eye, I think it's important to try to avoid phacoing close to the corneal endothelium. So if the power comes from a sculpting phase, which all takes place in the bag, I don't think that that has a real adverse effect on the corneal endothelium compared to using more power during phacoemulsification on quadrant phase, where you may have pieces bouncing up into the cornea. Here I'm going to slow down the video to a normal speed and just show how I'm taking this piece of cataract here. I'm using my second instrument to help make sure that the cataract piece stays behind or below my phacotip. And then I'm going to take the pieces just as slowly as necessary. I kind of go up and down on the foot pedal here just to minimize the amount of phacoemulsification used. And the key is to do all of the phacoemulsification as far away from the corneal endothelium as possible. So it's a little bit hard to appreciate in this video, but basically all my phacoemulsification is taking place at the iris plane or below, underneath quite a shell of endocoat that's protecting the corneal endothelium. So here you can see that I've removed a little less than half of the nucleus so far. I'm making a groove that's not in the center of this remaining piece. That's because I plan on making another groove, so there's actually 5 grooves in this case instead of my usual 4. Again, that's to try to phacoemulsify as much of the cataract inside the bag as possible, and I get smaller chips that are easier to manage and keep at the iris plane or lower. INA, I'm going to speed through pretty quickly. Really, there's nothing unusual about this case. We obviously don't want to break the capsule when we do an INA, and we want to be efficient so that we're limiting how much irrigation goes into the eye. But this is just a routine INA case. Again, I'll remind you that this is a 6mm optic on a ZC Boo. So as it unfolds, you can see really the size of the anterior capsulotomy is quite a bit smaller than the size of the optic. That's exactly what we want. You do have to be a little bit careful with such a small capsulotomy that you don't accidentally engage the anterior lens capsule with your phacoemulsification tip. You also have to be a little bit careful when you're unfolding the lens just to make sure that that trailing haptic makes it into the bag. If the trailing haptic opens anterior to the lens capsule, it's difficult to get it back into the bag, although it can be dialed back in. We hydrate the wounds at the end of the case. We remove the viscoelastic. Here I'm going behind the lens. Now I'm in front of the lens, removing the additional viscoelastic. We'll finish the case by hydrating the wounds one more time, and then I use intracameral Vigamox. The patient's cornea was pretty clear on the first day post-op, and I think she'll do well. Thank you for your attention to this case.